therapists are essential members of the healthcare team. We work with patients across the lifespan: children, adults, older adults. Many of these patients have underlying heart conditions. Understanding these conditions is not optional. It is fundamental. We must recognize signs of cardiac distress and modify our treatments accordingly. This knowledge protects patients from harm and helps them achieve the best outcomes. Our role extends beyond musculoskeletal rehab. We are often the first line of defense for cardiac changes. This guide is a practical tool for physical therapists. A myocardial infarction, commonly known as a heart attack, is a serious medical emergency. It happens when blood flow to part of the heart muscle is blocked, usually by a clot over atherosclerotic plaque. Without oxygen-rich blood, the affected heart muscle begins to die. Damage depends on the artery involved and time to restore blood flow. Infarction permanently damages the heart. Scar tissue reduces ejection fraction. For PTs, an MI history changes care. Expect lower activity tolerance and progress conservatively. Classic signs include chest pain or pressure, squeezing or heaviness, possibly radiating to the left arm, jaw, neck, or back. Not everyone has classic symptoms. Women, older adults, and people with diabetes may present atypically. Watch for shortness of breath, profound fatigue, nausea, or lightheadedness. If symptoms appear during therapy, recognize MI and act immediately. Post-MI risks include arrhythmias, heart failure, and reinfarction. Monitor HR, BP, SpO2, and symptoms every session. Congestive heart failure does not mean the heart stopped. It means it cannot pump adequately. Inefficient filling or pumping leads to fluid backup in lungs and peripheral tissues. Shortness of breath with activity or lying down is common. Look for swelling in legs, ankles, and feet. Check for pitting edema. CHF is chronic and progressive, impacting daily function and exercise tolerance. PTs use carefully prescribed activity and education to improve function safely. Key signs: dyspnea, persistent cough or wheeze, white or pink-tinged sputum, rapid or irregular heartbeat. Track swelling and weight. 2 to 3 pounds in a day, 5 in a week is concerning. Overexertion can precipitate acute pulmonary edema. A medical emergency. Monitor closely each session. Any decompensation requires stopping activity and notifying the medical team. An arrhythmia is an irregular heartbeat. The heart's electrical system misfires. It may be too fast, too slow, or irregular. Some are benign, others increase risk of stroke, heart failure, or sudden cardiac arrest. PTs need basic rhythm understanding and exercise implications. Atrial fibrillation features chaotic atrial activity and an irregular, often rapid rate. Blood may pool and clot. Anticoagulants reduce stroke risk. During exercise, HR response can be unpredictable. Monitor closely. Occasional PVCs are common. Frequent or paired runs may signal excessive cardiac stress. If pulse becomes very irregular or palpitations occur, stop, document, and communicate with the team. No device type and settings. Keep exercise HR well below ICD therapy thresholds to avoid shocks. As physical therapists, close observation is critical with cardiac patients. Specific red flags require immediate action, not later documentation. Any chest discomfort, squeezing or heaviness, possibly radiating to the jaw, neck, shoulders, arms, or back. Stop activity, seat the patient, and assess using PQRST. Provocation, quality, region, radiation, severity, timing. Assist prescribe nitroglycerin as directed. If pain persists, activate emergency response. Sudden, disproportionate breathlessness, wheeze, or gurgling may indicate acute pulmonary edema. Stop and seek help. Dizziness, pallor, diaphoresis, confusion, faintness, or abrupt HR rhythm, change demand action. The rule is simple: stop, assess vitals and symptoms, and get help. Your vigilance is a vital safety net. Post-cardiac surgery patients require unique care. Many have a sternotomy. For 6 to 8 weeks, protect the healing sternum from excessive stress. Standard precautions: no lifting, pushing, or pulling over 5 to 10 pounds. Avoid both arms overhead or out to the side. Do not reach behind the back. Teach splinting with a pillow during movement and avoid pushing with the arms. Our job is to teach, reinforce, and modify activities to honor precautions. Expect deconditioning after ICU and bed rest. Weakness, reduced endurance, and impaired balance. Start with bed mobility, safe transfers, and brief ambulation. Monitor response. Ensure pain is controlled to enable deep breathing, effective coughing, and participation. Teach splinting and proper mechanics. Poor pain control raises pneumonia risk. Coordinate closely with nursing for optimal timing of therapy. Phase 1 begins in the hospital once the patient is medically stable, often as early as 1 to 2 days after MI or surgery. We aim to counter muscle atrophy, orthostatic hypotension, and blood clot risk. Assess first. Review the chart, check heart rate, blood pressure, respiratory rate, oxygen saturation, and auscultate heart and lungs. Begin with sitting at the edge of the bed and monitor responses. Progress slowly from ROM, to sitting, to standing, to short hallway ambulation. The first walk may be 50 feet. Monitor vitals before, during, and after. Increase duration and frequency, not intensity. E.g., 2 minutes 3 times daily, building to 5 to 10 minutes. Educate on their condition, self-monitoring, precautions, and energy conservation. Empower patients and families for a safe transition home. Phase 2 is a structured, monitored outpatient program starting weeks after discharge. Patients typically attend 2 to 3 times per week for several weeks or months. Sessions include continuous monitoring of heart rate, blood pressure, and rhythm. Each session includes warm-up, aerobic conditioning on treadmill, bike, or elliptical, and a cool-down. Intensity is guided by stress testing, target heart rate ranges, and perceived exertion. Aim for moderate intensity that challenges without overstressing. After sternum healing, usually 8 to 12 weeks, add light resistance training. Start with light weights or bands. Focus on major muscle groups, proper form, and breathing. Progress strength training slowly and cautiously. Phase 3 is less supervised or self-supervised in rehab facilities, community gyms, or at home. Focus on sustaining enjoyable activities and a long-term plan for safe progression and risk reduction. The physical therapist's role in cardiac care is profound and indispensable. We guide patients from acute crisis to independence, bridging medical care to meaningful life. Vigilance is essential. Recognize myocardial infarction, CHF exacerbations, and dangerous arrhythmias, and respond to red flags. Combine objective vitals with subjective feedback to tailor interventions safely. Cardiac rehab is a progressive, monitored journey through phases 1, 2, and 3. We help patients overcome fear and rebuild confidence. Be active again, play with grandchildren, travel, and enjoy hobbies. Clear guidance, encouragement, and a safe environment empower participation. We strengthen hearts and restore hope, the true heart of our profession.